We're taking this, 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 we're taking with a pinch of salt.
Ladies and gentlemen, thank you for tuning into another episode of A Pinch of Salt. My name is Andrej Kobane. I'm a nephrologist from Slovenia, and today we'll be talking about a topic that is crucially important to our dialysis patients, something that can drastically prolong or drastically shorten their lives and has a strong effect on the quality of life, and that is vascular access. With us today is Dr. Tamara Jemcov. Tamara is a nephrologist working at the Clinical Hospital Center in Zemun, Serbia, and she's also the new president of the Vascular Access Society. So the ideal guest for this talk today. Tamara, welcome to A Pinch of Salt.
Thank you very much, Andre, for inviting me to be the part of this episode of The Pinch of Salt. And I also want to remind you that I'm also the member of the ERA, not just the president of the Vascular Access Society. I'm a nephrologist, and I'm also the president. I'm also the member of the ERA.
Of course, yeah. We can't go into all the details, otherwise the introduction is too long. Thank you for bringing that up. Okay. So before I started to work long-term on dialysis, I didn't really realize how much of the time of a dialysis doctor is actually devoted to vascular access, trying to ensure its survival and thus the survival of the patient. It's really a topic of immense clinical importance. And it's also a field where many exciting new things are happening. But before we go there, let's first tackle some age-old dilemmas that might not be dilemmas anymore, if that's okay with you.
Okay, thank you.
All right, so
I'm waiting for you.
Yes. You're waiting for my tough questions. Okay, here we go.
Yes.
So the first one is, what is the best timing to create a vascular access? We don't want to be too late. We don't want to be too early. How can we find the sweet spot?
Actually, I want to say that it is important that we start considering vascular access as a plan for it when the GFR drops below 15 milliliters per minute. We should make a distinction between patients who regularly see a nephrologist and those who do not. For the patients with regular nephrology appointment, we can more reliably predict the need to start dialysis by monitoring and actually managing the blood pressure, anemia, hyperkalemia, and hyperparathyroidism. It is also important to note that older patients may experience different patterns. They can remain stable in stage 5 kidney disease for many years. Typical when they do begin dialysis, their GFR is around 10 milliliters per minute or lower. And considering that and generally accepting the recommendation for the maturation period of about 4 to 6 weeks for the AV fistula, we can actually estimate that up to 2 months may be needed for preparing before starting dialysis. These actions actually include vascular mapping, surgeon's examination, and potential early reintervention. So don't hurry. You have enough time, about 2 months, to prepare someone for the vascular access. And don't start thinking about preparing vascular access before your patients reach the stage 5 of CKD.
Okay, those are very simple messages. Thank you.
Yes.
So the second question would be, what is the best way to monitor a functioning fistula or graft? Do we even need to monitor, or to put it another way, it's better to prevent complications than face them when they're already done. So how would you suggest that we monitor a functioning fistula or graft?
I must say that actually the well-trained and educational nurses are our good fairies of successful and good hemodialysis. The nurses are the ones who are in constant contact with the patient's vascular access 3 times a week. They perform the puncture, they monitor how the hemodialysis is going, and actually react if any difficulties arise. High venous pressure, poor flow, constantly on alarm, prolonged bleeding after removing the needles, redness at the puncture sites. And every observation should be recorded and followed up over the time. When they alarm us, we should perform ultrasound. And ultrasound should be available in every center, and the staff should be trained to recognize and diagnose complications. It is not really demanding as a trip to the moon or brain surgery, so doctor or nurse can be trained relatively quickly. And finally, low dose of dialysis, KT/V, or a low URA reduction rate below 60% definitely are signs that we should start searching for the reasons.
That's great. So what we really need are nurses that are not afraid to tell us something is wrong, right? Nurses who are motivated to tell us when something doesn't feel right. And you mentioned ultrasound. That's a fantastic tool. The field really opened for me when I started doing ultrasound. And I'm not good at ultrasound, but it's just so useful, right? Just to measure the flow and see what's going on beneath, right?
Yes, and so, really, it depending on center to center, of country to country. In some centers, besides nephrologists, you have also some centers that are very trained nurses who are devoted to vascular access, and also they're educated to use ultrasound to orientate what is happening with the flow, and also to puncture under the ultrasound. But we should use it more than we use it. We should use it more.
Sure. Is there anything new in interventional nephrology in terms of vascular access? Is there anything you would like to point out as something that we need to be aware?
But not so new in the interventional nephrology. We have PTA, we have drug-coated balloons, we have cover stents for central venous stenosis. So that's it. There is no new players on the stage, actually, in the interventional nephrology. But there are something new. I will tell you if you ask me about the last Congress. We have some news on the last Congress that was.
I will definitely ask you about the last Congress, so we can keep that for later. By the way, what's your view on drug-eluting balloons? Do you think that that's worth doing, or?
I think that they have some places in interventional nephrology when we are talking about the fistula stenosis. But I will let it to the interventional nephrologist.
Okay.
I will not. I don't have enough experience with that. But there are some papers that are very, very good in that. Favor the drug-coated balloons.
Great. So catheters, tunneled versus non-tunneled. Is this even a debate? Should everybody have a tunneled catheter? Or are there situations where a non-tunneled is good enough for a while or for a phase? Or how do you see this debate? Is this even a debate?
It is still debate.
Okay.
Tunnel catheter is recommended as an option of permanent vascular access. You are aware of that. You are from Slovenia, and Slovenia has good experience for years with non-tunneled central venous catheter. There is also on the market non-tunneled antibacterial central venous catheter coated with silver, which is an option in between. I think that main thing is to be wise and decide according to the patient characteristics, age, expected survival time, social status, comorbidity, certainty of the future transplantation, and finally the availability of the professional who will insert the tunneled central venous catheter. and also, and depending on that, what type of central venous catheter should be placed. Actually, in my country, we usually insert non-tunnel catheter to overcome the time for creation, to overcome the time from creation of heavy fistula till the maturation process and to start hemodialysis, and also to overcome the period for starting PD, peritoneal dialysis. We only place the tunnel catheter in patients who do not have other options for permanent vascular access. But I have to admit really that central venous catheter in patients with poor blood vessels, heart failure, and oncology patients can be really, really good options if they are well placed and used in accordance with strict aseptic rules. So it depends on the country, on the center, and on the praxis. I think that professions who are involved in hemodialysis should decide should they use non-tunnel central venous catheter, maybe for a prolonged time, and when to switch from non-tunnel to tunnel central venous catheter.
Okay, thanks for that insight. So yeah, there's no simple answer, of course, as always in medicine. So yeah, you've mentioned already the 14th Congress of the Vascular Access Society that took place in Padova this year, and I really wanted to ask you about that because unfortunately I didn't go there myself, but I was watching the program, and it was amazing to me. Such a wide range of talks and participants. It really looked great. So you were obviously there as the president, and what would you point out as the major highlights of this Congress? What are some new exciting approaches in vascular access?
Thank you for this observation, but you will have opportunity to come and visit Belgrade in 2027. Another Congress, 15th Congress, will be held in Belgrade, so you are invited to come.
Thank you very much. Lovely to come to Belgrade always. Yeah,
come and also to visit the Belgrade, and also to be during the time of the coming Vascular Access Congress in Belgrade. I want to tell you that we were very, very proud and happy because we have really, really good lecturers during the Congress in Padova. There was present actually now actual president of the ICN, Prebiroy Chaudhary, nephrologist, and also there was Charmaine Locke. She was a chairwoman or chairman of the last KDOCI guidelines on vascular access, and we also has Professor Ronko from Vicenza as a lecturer. What I want to point out, three things. Actually, colleagues from Netherlands have presented a device under development that use magnetic force to connect an artery and a vein during hemodialysis while remaining close outside of hemodialysis. It is something which is new, and we will see in the future how feasible this idea is in the real life. There was also presented the first result of the new graft. It is a vascular access implant, a graft that stimulates the development of the new natural tissue. And the results of the pivotal trial of the implant at 18 sites across Europe show that this new type of graft achieved superior sustained patency in both primary and secondary outcome compared to other arteriovenous graft, and also demonstrated a higher infection resistance than other types of graft. I have also to mention that researchers are doctors, and also researchers and doctors from Netherlands are both which presented these devices and these grafts. And it is also, I think that it is something that has something with William Kolb, who was actually the father of the hemodialysis. And that's two things that I want to mention, and also what was also mentioned in this in the last Congress in Padova, that percutaneous AV fistula as an option has not proven to be cost effective compared to classical surgery. These are three things that I should and want to single out from this last Congress in Padova.
Great, so many new things going on, and yeah, maybe you're right. Maybe there's something about Netherlands that allows people to be pioneers in nephrology, I guess.
Yes.
whatever that may be. So for the penultimate question, I just wanted to ask you. Now you've devoted a lot of your professional life to this field, but most of us are not really so much into vascular access on a daily basis. So what would you point out for those of us who are not dedicated to vascular access? What would you point out as three things that we need to take care of, need to be more vigilant about? Three advices you would give, perhaps.
I want to say that hemodialysis still remains the most common treatment modality for patients with end-stage renal disease. And therefore, vascular access is of a crucial importance and significantly influence the quality of life of our patients. So we have to be aware of that. I want to send a message that use ultrasound in your everyday practice. It is a really, really potent tool in your hand, and you can really, really do. You can put a central venous catheter under the ultrasound. You can see what is happening with your blood vessels and what are the quality and characteristics of the blood vessels from your patient before creation of AV fistula, and before you decide what type of vascular access or hemodialysis access you will send your patients. And later during follow-up, you can also very quickly and very reliably detect any complications on vascular access. So use this ultrasound. And if cardiologists have taken over performing coronary angiography and addressing critical stenosis, nephrologists can follow suit.
Yeah, sure. It's also my experience that once you start doing ultrasound, it's a whole new view opens, and that nephrologists can be very good at surgery or intervention. I've seen that myself. As long as you're passionate about the field, everything can work.
And we also, Vascular Access Society, I want to remind you that there was an initial, both ERA and Vascular Access Society joined the ERA in NPAT project.
Mm-hmm.
And I think that we will continue to work on this and to implement and to invite and to motivate more nephrologists to join this direction, to go in interventional nephrology.
Yeah, it's great that you mentioned that. NPATH is really a wonderful website. You can see a lot of videos there, a lot of things. You can learn a lot from just that website. It's true. Thank you for mentioning that. So now we go to the last question, which is more about you than vascular access. I hope you don't mind. So the question is, which book, 2 songs, and luxury item would you take to a desert island?
I recently read a book, Semper Idem. It is a book written by a Serbian writer, George Lebovic. And it is a chronicle of a childhood on the eve and during the World War II. I will take this book, and so many true in this book. I won't take any luxury item to the desert island, so I will replace it with two more songs, if you agree
Yeah,
with
that's
me.
good. That's good. Okay, sure, sure. It's your choice.
There's several songs that I like very much. The first one is The Perfect Day, Lou Reed, or Duran Duran, whatever you like. The
Definitely Lou
folk,
Reed. I'm sorry.
yes,
That's,
yes.
my subjective opinion, but yeah,
Uh,
sure.
Every Breath You Take, Police.
Okay.
Heroes, David Bowie. And finally, Love is in the Air.
That's
John Paul Young, an Australian singer. I like this song very much because it is optimistic.
that's a great selection. Very varied, very different for different occasions. That's a good choice.
Yes,
Thank you.
thank you.
So, Tamara, really thank you for giving us all this advice. And we'll try to think more about vascular access, at least I will. And thank you for everything that you're doing in the Vascular Access Society.
You're welcome. You're welcome for this interview. Thank you very much. And also, I'm expecting you to come to Belgrade in
Thank you.
2027.
I'll definitely do my best. Thank you. Thank you. Bye bye.
Okay, thank you. Bye bye.